COVID-19 vaccines and clotting risks. What the research says. The COVID-19 pandemic brought vaccines into sharp focus, saving millions of lives but sparking concerns about rare side effects like blood clots and heart inflammation. Social media, especially platforms like X, have amplified claims about vaccine-related risks, including sudden cardiac death in young people. This article combines findings from large-scale studies to clarify the risks of brain, lung, and heart clots, as well as sudden cardiac death, in vaccinated and unvaccinated individuals. The goal is to cut through the noise with clear, evidence-based insights. Brain clots, a rare but serious concern. Cerebral venous sinus thrombosis, CVST, is a rare type of brain clot that has drawn attention due to its association with certain COVID-19 vaccines. Studies, particularly from 2024, show a small increased risk with adenovirus-based vaccines like AstraZeneca and Johnson & Johnson, J&J. A global survey of 99 million people found a 3.2 times higher than expected risk of CVST after the first AstraZeneca dose, with 69 cases observed versus 21 expected. For mRNA vaccines, Pfizer and Moderna, the risk is lower, a 1.49 times increase after the first Pfizer dose and 1.25 times after the second. The condition linked to these clots, vaccine-induced immune thrombotic thrombocytopenia, VITT, involves low platelet counts and clots in unusual sites like the brain. The risk is estimated at 10 per million for AstraZeneca and 3.8 per million for J&J. In contrast, COVID-19 infection poses a far greater risk. A 2021 Oxford study reported a CVST incidence of 39 per million in COVID-19 patients, compared to 4.1 per million in vaccinated individuals, a 6.36-fold higher risk. This gap highlights that infection is a much stronger driver of brain clots than vaccines. Lung clots. Infection outweighs vaccine risk. Pulmonary embolism, PE, a clot in the lungs, is another rare but serious condition. Adenovirus-based vaccines, particularly AstraZeneca, have been linked to PE in cases of VITT, with fewer than 1 in 100,000 cases reported. mRNA vaccines show no consistent association with lung clots. Meanwhile, COVID-19 infection dramatically increases PE risk. Studies estimate that 5 to 40% of hospitalized COVID-19 patients develop clots, including PE, with rates as high as 20% in ICU patients. This compares to a general population risk of 1-2 per 1,000 annually. The virus triggers endothelial dysfunction and immune activation, promoting clots far more than vaccines do. Heart clots and inflammation, myocarditis in focus. mRNA vaccines, Pfizer and Moderna, are associated with a rare risk of myocarditis, an inflammation of the heart muscle, especially in young males after the second dose. A 2024 study of 99 million people found a 6.1 times higher than expected rate of myocarditis after the second Moderna dose and a 2.7 times higher rate after the second Pfizer dose in males aged 16-25. Rates range from 147 cases per million in young males, peaking within 7 days post-vaccination. Most cases are mild, with 82% showing myocardial injury on MRI, but 60% had persistent scarring at a median follow-up of 178 days. Adenovirus-based vaccines like AstraZeneca are more linked to pericarditis, inflammation of the heart's outer lining, with a 6.9 times higher risk after the third dose. Arterial thrombosis, which can lead to a heart attack, is rare but reported with AstraZeneca in case studies. COVID-19 infection, however, carries a much higher risk of heart complications. Myocarditis rates are 64.9 per 100,000 in infected individuals versus 35.9 per 100,000 post-vaccination. Infection also increases heart attack and stroke risk by 60 to 230-fold compared to vaccination. A 2024 study of 46 million English adults showed vaccination reduced cardiac events 13-24 weeks post-infection, compared to unvaccinated individuals. Sudden cardiac death in young people. Concerns about sudden cardiac death, SCD, in young people, ages 16 to 30, have fueled debates, especially